And welcome to these deliberations in Obs and Gynae once again. We'll be doing the discussions on the obstetrics part of the video-based questions now. And as we did in gynecology, we have a few questions which will remind you of the common topics, but in a special way, because you know what happens, you know the theory. You have been reading for the last 6-7 months very intensively for this NEET PG exam or maybe for your FMG exam, but still remember, whenever you read, always try to visualize things, because it's not going to be any difficulty if you visualize things. And what is the best? That you can now visualize things, because everything is available on the YouTube or on the images. Everything is actually much easier now. I mean, I remember that when I was in my MBBS, if I had a few doubts, we used to make these small diaries and we had these doubts. We used to write some, 50, 60 doubts in a week. And in the weekend, we used to go to the library and we used to try and get all these doubts sorted out from multiple sources, multiple books. And after 5 doubts, we would get tired and go out for a cup of tea. And you'll eventually learn by, by the clinical life which you've lived, and then we learn. But now the time is so so much simpler for all of us to read, because whatever you have a doubt about, you can see on the internet all the images and all the surgeries. Whenever I do a new surgery, I put it somewhere on a forum and it's available for the youngsters to see. So it's very handy that please use the media for helping you to visualize the concepts which you're learning, right? Chalo, let's get into obstetrics today, and this is the first question here. And the first question here is, the following procedure is showing a dedicated instrument for retraction. What is the name of this instrument? I will ask you this question a little later. See the question which is written first, and then I'll ask you the next question. What is the instrument shown here? Come, this is a cesarean section. Yes, this is the instrument which I want you guys to see. Okay, see this instrument here. Maybe I'll show this video again to you. I'll start again. Yeah. What is this instrument here? What is the name of the instrument which is used here when I'm doing a cesarean section? Look, I'm trying to reach the lower segment. It's a very less space. I'm trying to stretch my fingers so that I can see the lower segment properly, and then I can make an incision on this lower segment and deliver the baby. So I'm using this instrument. Once again, I want you to see this instrument here. Can you see that? Yes. One of my junior friends like you, one of the interns, is mostly holding this instrument, and these are the ones, the interns who are helping us do the cesarean sections very easily. So what is that retractor? Is the Leach Wilkinson's? No, Leach Wilkinson is a cannula for injecting dye into the uterus when we're doing a hysterosalpingography or a laparoscopy, when we're putting the dyes. And Deaver's retractor, I'll show you what it is. Yes, I'm sure all of you got this correct, because that's the Doyen's retractor. Yes, Doyen's retractor is the one which is used to do the retraction during a cesarean section. Right. So the answer is definitely Doyen's retractor. C is the answer here. Now, what is the next thing? The next part which I'm asking you is, what is the purpose of this retractor? Yes, again I'm trying to show you, this is the Doyen's retractor here. What is the purpose of this retractor? You're doing retraction only of the abdomen wall? Now, see, that's not there in the choices. I just want you guys to know what we're trying to do here. Once again, if you see this picture, this video rather, if you see this, we have applied this retractor to retract the lower incision, the lower part of the incision and the abdomen wall. But I'm also actually dissecting the bladder away from the lower segment of the uterus. The bladder sits, suppose this is the uterus, the bladder is sitting on the lower segment like this. So if I have to cut the lower segment, I have to retract the bladder. And when I retract the bladder, then only I can incise the lower uterine segment. So to reach the lower uterine segment, we must retract the bladder. So it is actually more difficult to do the lower segment cesarean section than the classical cesarean section. Classical cesarean section, this bladder I don't have to retract, I have to just make an incision here. I have to make an incision on the top of the uterus and I can take the baby out. But why don't we do it? Because when I do a lower segment cesarean section, next time I can do a trial of labor after a cesarean section, vaginal birth after cesarean section. That's why a lower segment cesarean section is done. So to do a lower segment cesarean section, you must retract the bladder, and that's the purpose of using the Doyen's retractor. Okay, the next one is a little tricky. Okay, before I go to the question, some more retractors. The Balfour's retractor is this one. This has a Doyen's like instrument to retract the lower abdomen wall, and this is a self-returning retractor. We can retract the abdomen wall like this. So when you're doing a longer surgery and you have to go deep into the pelvis, like when we do a Wertheim's surgery, Wertheim's hysterectomy, when we're doing radical dissections and all of us are getting tired of. So this self-rotating retractor, the ball force retractor we use, you know, you can retract, and then there's a key here. You can retract the lower abdominal wall, you can retract the side abdominal walls, and then you can fix it so that you can aram to do the surgery. So that's the ball force retractor. And then this, the Devers retractor. Devers retractor is again to retract the abdominal wall to reach the depth of the pelvis, so that we can, when we are like hitting the uterine arteries and it's deep in the pelvis, or you dissecting near the uterine arteries, you're trying to, you know, retract the ureter, dissect the ureter away from the uterus when we're doing a radical surgery, then these deep retractors, internal iliac artery ligation, all of the surgeries, we use this retractor, the Devers retractor. Of course, it's used in general surgery also. Right, so that's question number 1. Now let's get into question number 2, and I'll read the question first. What is the best surgical management of the lesion shown in this laparoscopy of a primary gravida? Okay, this is a woman who is pregnant for the first time, and there's a lesion which I'm going to show you in the laparoscopy. And what is the best surgical management of this? So yes, you can see there is a lesion here. I'm now with my instrument, you know, with my grasp, I'm trying to show you. Can you see? While I was making this video, I was keeping my students in my mind so that I can, you know, show you how the parts of this. Can you see once again? So this is the uterus, this is the fallopian tube, and I'm pointing out a segment of the tube which has a swelling. So it's obviously a swelling in the fallopian tube. So if there's a swelling in the fallopian tube, we are going to ask you only about an ectopic pregnancy. So if there's an ectopic pregnancy, what is the best surgical management of this lesion in a primary gravida? See, now you have to use your basic understanding. You can make out by this that it's an ectopic pregnancy. What kind of ectopic it is? Are you seeing any blood? Are you seeing any blood in the abdomen here? In this laparoscopy, are you seeing any blood? No, you're not seeing. Are you seeing any rupture in the tube? You're not seeing. So it's an unruptured ectopic pregnancy, and we are doing a surgical management. So it's understood that the criteria has been met for doing a surgical management. So when you're doing a surgical management, what is the best surgical management? Yes, a lot of you are saying answer is D, because that's a linear salpingostomy. Resection anastomosis, nobody wants to say. You can do a resection anastomosis. Yes, that is a surgery which you can do. Yes, that is a surgery. You can chop the tube from here and re-anastomose. A much more difficult surgery, but it can be done. So remember, resection anastomosis is a option which is correct, but the best option is obviously what you guys have written, and that is a linear salpingostomy. You'll make a incision on the tube and take the products out and leave the incision. Okay, let me try and show you. See, don't do total salpingectomy because she's a young lady. She wants to, she's a primary gravida. She wants to save the tube so that she can have children next. And partial salpingectomy is never done. There's nothing called partial salpingectomy. I don't know why it is there, still mentioned in so many books. Please remember, nobody does a partial salpingectomy. There are people who've been penalized by the law. Yes, there have been cases against people who've done partial salpingectomies, and people have had an ectopic in that segment which was left behind. So do not even think of writing. So a lot of books are giving you some 30 surgeries for ectopic pregnancy, and you don't have the basic concept of ectopic pregnancy management. So basic is, if it's a ruptured tube, do a total salpingectomy. But if it's an unruptured tube, then you want to save the tube. Now, how you can save the tube? You can do a medical or a surgical conservation. So what is a surgical conservation? Linear salpingostomy. So let me show you what is a linear salpingostomy. See here, this now, if you see this picture here, look at this same patient. Now you see the tube is a little distended because I have injected something called the vasopressin injection in the antimesenteric border. This is the antimesenteric border. The top of the tube will be antimesenteric. The bottom of the lower part of the tube will have a mesenteric. So antimesenteric border, I have injected the vasopressin. That part I am not showing you. Now I am showing you the part where I am doing the surgery. Wait a minute. Oh God. So what happened to the video? Yes. See this. This is the linear incision. Okay. So that is the lengthwise incision which I have made. once again. Yeah, once you make that lengthwise incision, once you made that incision, you can see that the edges will bleed. So these edges are cauterized, all that I'm not showing you here. Next is that these edges, the bleeding stops and the products have to be removed. So that is the gestation sac inside there. So come, we'll show you that also. Yeah, see. Now, how do you remove the gestation sac? We don't generally pull it out. What we do, we actually do a hydrodissection. So I have this cannula which is pushing, saline in high pressure, and you can see the placental tissues, the villi, the fronds are coming out here first, and I'm still using this hydrodissection, and you can see now, yes, this is the part of the gestation sac. There is some bleeding in it already because of whatever procedures we are doing. So this gestation sac and the villi fronds will come out, and once they pop out, can you see the edges are not bleeding at all? Because before I do this, I would have done cautery of the sides. So linear salpingostomy, I made an incision and took out the products. I did not do a suturing. That is called salpingotomy, and nobody is asking you salpingotomy anymore. Linear salpingostomy is the word which I have taught you just now. Okay, so linear salpingostomy, make an incision and do a hydrodissection, take out the products, and that is the conservative surgery for a unruptured ectopic pregnancy. So now, what is the management of a unruptured ectopic pregnancy? You can do a medical management of unruptured ectopic pregnancy. That is, you can use methotrexate, that is the most common drug used, and then the potassium chloride injection, or you can use mifepristone. Many other drugs have been tried. Mostly we are asking about methotrexate. Another question coming up in the same lecture about this. Okay, and then we can do surgical management of an unruptured ectopic pregnancy, which is linear salpingostomy, which you just now read, and there's another one which is the resection and anastomosis, rather difficult method to do the management, and there's still another one known as the milking of the tube. Now, what is the milking of the tube? The ectopic, which is like this, you squeeze the tube like this and you milk out the products, and you enforce a tubal abortion while doing the surgery, milking of the tube, and this is a surgery which is not done anymore. Please, it is there in the books, I don't know why. Please, we do not do milking of the tube. If you're trying to save the tube and you save it by milking the tube, you're actually destroying the tubal architecture altogether. So please don't do any milking of the tube. That's not done anymore. I've seen people trying to explain the juniors ki milking kaise ki jati hai. Please guys, if anybody, all you PGs, if some seniors teach you about milking of the tube, please tell them that this is not done. This actually spoils the tube. So we do only linear salpingostomy or resection and anastomosis, and out of that also linear salpingostomy. So the criteria, yes, all of you know, the size should be 4 centimeters, and if it is more than 4 centimeters, we do surgical management. HC should be 5,000 international units, and if it is 50,000 ho gaya, okay, take it out, 5,000 guys. So HCG is 5,000. If it is more than that, linear salpingostomy. Cardiac activity, if it is present, then this surgical management. So all this surgical management, if the size is more than 4, HC is more than 5,000, and cardiac activity is present. Now, we can do medical management if the size is smaller than 4 centimeters, HCG is lesser, and cardiac activity is absent. Cardiac activity is absent, I'm sorry. Cardiac activity is absent. So now try and understand that even if one value is on the right side, then we will go ahead and do a surgical management, right? So yes, once again, cardiac activity absent and cardiac activity present. So keep that in mind. So that is the management of an unruptured ectopic pregnancy. Just a quick revision. Now, the surgery shown here on the fallopian tube is a common procedure in emergency obstetrics. The tube is seen here in the background of significant hemoperitoneum. What is the most likely site of the lesion which required this surgery? So, another video guys. The surgery shown here is a common practice in emergency obstetrics. The tube seen here is in a background of significant hemoperitoneum. Can you see there is blood all over the place? And what we are doing with this tube, can you see that? Yes, what has been done with this tube? See, the ovary has been left behind and the tube has been snipped, totally snipped. Once again, yes, here Can you see we have cauterized the base of the tube and then we have done a total salpingectomy. So when we do a total salpingectomy, that is the management of a ruptured ectopic pregnancy, you can make out there is so much of blood in the abdomen. This patient had almost 3.5 liters and she was in shock. Now you tell me, when you're doing, of course, this is a laparoscopic procedure. In shock, laparoscopic procedure, please only senior doctors should be doing. Anyway, so when we're doing this, what is the most likely site of the lesion which required this surgery? Now that's the question. You know the surgery. You've been told just before in this session itself that linear salpingostomy for unruptured ectopic and total salpingectomy for a ruptured ectopic. Now you're seeing a total total salpingectomy of a ruptured ectopic pregnancy. What is the most common site of rupture of this ectopic pregnancy? Yes. How many of you are saying A and how many are saying B? Okay. Yes, Jayalakshmi has got it correct. Most common site of lesion, meaning most common site of ectopic. Yes, obviously correct. That's the right way to look at it. So most common site of an ectopic pregnancy is obviously the ampulla. Okay. Do not get into any confusion. Ampulla is 70% of the ectopic pregnancy. Okay. So if you written ampulla, then I'm happy all of you are correct. Yes, most of you are writing ampulla, and isthmus is the earliest to rupture, not the most common ectopic. Okay. So yes, just for a quick revision. So isthmic ectopic is 11% of the ectopic pregnancies, ampullary is 70%, and interstitial cornual is a very rare ectopic pregnancy. Now, when does the isthmic ectopic rupture? It is the earliest. It is the earliest to rupture, and the ampullary ectopic is the commonest rupture. This is the commonest rupture. So earliest to rupture, if at all they ask you, you can say isthmic, but the commonest ectopic, 70% ectopic will be the commonest to rupture. If ectopic happens in the ampulla most, then it will rupture in the ampulla most. And then the rare ectopic is the interstitial cornual. I'm not saying rarest. Rarest, yes, rarest ectopic. Anybody? I'm keeping it open. Please, I'm waiting for your answer, guys. I want some answers there. Rarest ectopic कौन सा होता है? There are many other sites. Abdominal, ovarian. I'm not mentioning the other sites. सोच के बताओ. So interstitial cornual, this is the last. Why interstitial or the cornual ectopic will rupture at the last? Because you see the tube traverses through the uterine body, and this part where it traverses, if the ectopic is here in this part, so the uterine muscle will grow along the growing ectopic. So this grows for a long time before it ruptures. So this will rupture at 12 to 6 weeks. Although the narrowest part of the fallopian tube is the interstitial part, this intramuscular part. This is indeed the narrowest part of the fallopian tube. Isthmus is narrow, but the narrowest is the interstitial part. And this time, remember that if the ectopic is here, it will grow for a long time before it ruptures. Okay. Now, what is the rarest? Uska answer though. Ovarian is not the rarest, guys. Ovarian is not the rarest. That's a tough question now. So we have ovarian ectopic, we have abdominal ectopic, and then we have a cesarean scar ectopic. Which cesarean scar? The uterine scar, not the abdominal scar. The uterus के ऊपर जो हम लोग incision करते हैं, lower segment or upper segment, whatever you call it. So the uterine scar is also there, and then there is cervical ectopic. So yes, there was always a talk between, sir, whether the scar ectopic is the rarest or whether the cervical ectopic is the rarest. Let's see. So you got the choices. Surgical site, abdominal ectopic is not the rarest, no. Choices between the uterine scar and the cervical. So I remember when I was doing my MD in JIPMA, my boss used to tell me that he had seen one case of a uterine scar ectopic, because we used to do so much of normal deliveries then. Now the cesarean sections are increasing so much. I have seen 11 cases of cesarean scar ectopics. That's a lot. But because so many cesareans are happening, so that's why we have a lot of cesarean scar ectopics. Now, still rarer is the cervical ectopic. Okay. So yes, most of you got it correct now after the a little bit of hint. So I can now see Ugrasain. All right, you got it correct. Smooth specialist, and Ravi and smooth specialist. That's a wonderful name you have. That's your handle. All right, great. So these are the management options, and the rarest ectopic is the cervical ectopic. Cesarean scar is still rare, but not the rarest. All right, Chali, let us see what is depicted by the marker in this early pregnancy scan. Marker means something will come on the screen and show you. So this is a transvaginal. Can you see this is the transvaginal ultrasound probe, and we are doing an ultrasonography in early pregnancy, and a marker is going to just come on that. Can you see now? Can you see? Yes, can you see this plus sign? This marker is trying to show you something here. Okay, I'll show you with my pen. What is this here? This is the head of the baby. This is the body of the baby, and there was a heartbeat here somewhere. Again, I'll show you. See, this is the heartbeat here. Yes, it's an intrauterine pregnancy. Yeah, there's no problem. It's an intrauterine pregnancy, and this marker is trying to show you something here. It's a very nice depiction of something which we ask in your Viva exams. All you MBBS students are watching this. Viva में पूछेंगे आपसे, picture देख देंगे, बताएंगे what is this? Just to trouble you sometimes. Tough है थोड़ा सा. Okay, tell me. Is the yolk sac, is the gestation sac, is the developing placenta, or is it a smaller twin, dichorionic diamniotic twin? Yes? Yolk sac, gestation sac. So guys, this is the gestational sac and this is the yolk sac. And you can see the yolk sac is getting pinched out. It is getting pinched out from the sac. What happens? I'll show you this in a picture here. Can you see this G sac here? And can you see this yolk sac? Around 7 weeks. See, the yolk sac is the primitive hematopoietic system. You must understand that in an early pregnancy, you see a gestational sac first. Gestation sac comes first. Then you see a yolk sac next. And this yolk sac will have the fetus growing next to it. So this is what is called the fetal node. Fetal node. And then after some time, this fetus becomes big enough like this. Next is this stage, fetus becomes big enough. And this yolk sac here, this yolk sac, it gets pinched out. It gets pinched out. Around 7 weeks, it gets pinched out. It is just like that. Once the yolk sac's requirement is gone, then it gets pinched out. So it is here like this. You can see this is a gestation sac. This is the yolk sac. So yolk sac gets pinched out of the amniotic sac. It just gets pinched out. Once it gets pinched out, then the uterus obviously has the placenta which is formed, and that placenta will be the source of the the nutrition to the baby. Earlier it was the yolk sac, right? So those who got yolk sac as the answer, you've answered it correct. Ciao. Let's see something else. Ugrasen, since 12th standard, right? That's a heavy compliment, but thank you so much. Accepted. Okay, Chali, let's move on and see something else. So a procedure is being done for the management of this ectopic. Sorry, I'm a little heavy on ectopic pregnancy today. I just realized while taking the session because I had a lot of videos on that. So never mind, at least one topic will be very sure in addition to cesareans. Okay, a procedure is being done for the management of this ectopic pregnancy. What is the most common drug used in this procedure? Guys, be very careful. Don't please, this is only a session before the exams. Don't rush to the answer, don't jump to the answer. Please see the procedure which I am doing here, and this is done in one of my ectopic pregnancy patients. This was in fact a scar ectopic, but we are just asking what is the most common drug. Can you see this? I've given you a lot of hints. See, this is the transvaginal scan, this is the uterine wall here. You can't make out, it's a little zoomed in, but this is the ectopic pregnancy here, and a needle just came in. Come, I'll show this again to you. See this. This is the ectopic pregnancy. See, there's a heartbeat here. There's a pregnancy. It's a little zoomed in. There's a pregnancy here. Now the needle is coming inside. One needle is coming inside. See, one needle came. And now I'm going to, yes, I've reached the heart. Can you see I've reached the heart? And now, just now you'll see. Yes, some drug has entered. So it moved a little in the end. Some drug has been injected. Can you see some fluid came inside? So we have injected a drug into the heart of the baby in an ectopic pregnancy. What is the drug? Be careful. I have already warned you. I said I warned you. You guys, you're answering methotrexate. Yes, Jayalakshmi. Wonderful. Jayalakshmi, you got it correct. We are injecting KCL to stop the heart. Yes. Remember one thing. Always, I told you earlier in the discussion already that when we are doing management of unruptured ectopic pregnancy by medical management, the most common drug used is methotrexate. Correct answer. You can give it intravenous to the mother, intramuscular to the mother. You can give the injection directly into the sac also to degenerate the products, degenerate the pregnancy. But to stop the heart, we give the KCL. Yes, so many times in this patient, in fact, what did I do? First, I use KCL to stop the heart, and next I give methotrexate so that the other products, they do not keep persisting. We don't want a persistence of molar or persistence of trophoblastic tissues. I don't want any persistence of trophoblastic tissues here. They will keep having some blood supply at the edges and they'll keep growing. The baby has died, but the trophoblastic tissues will keep growing for a long time and the HCG will stay high and she'll keep having intermittent bleeding. So I want to stop the heart of the baby and then I want to degenerate. So I give KCL first. So what is the question? What is the most common drug in this procedure? So you have to understand. I'm showing you it's an ectopic pregnancy. I've told you it's an ectopic pregnancy. There's no doubt about that. And I've shown you needle is going inside. So if the ectopic pregnancy is shown a needle going inside and we're stopping the heart, it is the cardioplegic drug. We are inducing cardioplegia. So that drug is KCL. So the answer is D. KCL is the answer, potassium chloride. Okay. So yes, again, the warning which I gave you, most common drug for the medical management ectopic pregnancy, yes, you are correct, it is methotrexate. But for the cardioplegia, it is potassium chloride. Yes. So if you see some of my videos on the YouTube, you will see you can put scar ectopic pregnancy and Prassan Veg, and you can see something about the uterine scar revision, and you can read about the scar ectopic pregnancies. And then you, of course, scar ectopic is unlikely to come as a NEET PG question in more detail, but yes, scar ectopic pregnancy is seen. And how can it be managed? Mostly we do medical management, although surgical is also done. May come as a question. Yes, NEET PG, they will ask you somewhat difficult questions, so that can come. Okay, go ahead and see that video, and let's see something else now. So in the procedure shown here, what is the most common uterine incision? Procedure shown here, what is the most common uterine incision? Okay, fine. We are seeing the head of the baby here. Okay, fine. The whole baby has come out. Looks like a cesarean section. That's the umbilical cord. And my resident, okay, in a little bit of hurry, has not done the delayed cord clamping because this is a 4-year-old video. Fine. That's your yours truly in the video. So we have done an incision to take the baby out. All right. So that's that. Now, please tell me, when we're doing this cesarean section, what is the most common uterine incision? See, you know it's a cesarean section, but in the exam, don't get scared, okay? When we're taking out a baby, it has to be cesarean section, okay? So don't get, nervous when you see videos like that. So it's a cesarean section. So what is the most common uterine incision? Is it an upper segment vertical? Is it an upper segment transverse? Or is it a lower segment transverse or a lower segment vertical? Yeah, take your time. Take your time. I'm waiting for your answers. So, upper segment vertical, or is it a lower segment vertical, lower segment transverse? Okay, a lot of you saying C, lower segment transverse incision. Okay, fine. Now, most of you are answering this, so I'm not going to take much time and tell you what I want to tell you about the cesarean incisions. Remember, cesarean incisions can be abdominal incisions. So, abdominal incisions can be vertical incisions here, and they can be transverse. So, that is the abdominal incision on the mother's abdomen to enter the abdomen. So, this transverse is also known as the Pfannenstiel. This is also known as Pfannenstiel, also known as the bikini incision. Yes, it is the incision which is cosmetically much better, because if the lady after cesarean, later on in life, she goes to a beach, then the lower part of the bikini is going to cover this incision very easily. But if it's a vertical incision, then it is cosmetically, not very pleasing for the person. So it's actually called the bikini incision. Yes, so bikini incision or the Pfannenstiel incision or transverse incision in the lower abdomen. So these are the incisions on the abdomen. Now, once you open the abdomen, you enter inside and you have to do a uterine incision. Uterine can be a classical incision or a lower segment. Classical means the cesarean section, the first cesarean section. You know, there are a lot of stories. Some of them are, you know, now they are, they are refuted now, that Julius Caesar's mother, when she had a, delivery, that time the attending physician had to cut the abdomen and take the baby out. That was the first cesarean section. That's why this name is like the cesarean incision. All right. So that first was a vertical incision. Yes. As the cesarean section evolved, now we know that we can give a lower segment uterine incision, so that next time we can do a normal delivery, because upper segment contracts and lower segment relaxes. You know, that's how the contraction of the uterus is. Upper segment contracts, lower segment relaxes. That's why lower segment incisions are given. Now, when you give a lower segment incision, it can be low transverse. Yes, all of you said C are correct. Low transverse incision. So, lower segment transverse incision, this is known as the Kerr's incision. Kerr's incision. The lower segment transverse incision. But we can do a lower segment vertical incision also. So that is known as the Kreonig's incision. Kreonig's. Those who are German enthusiasts, they will know this is known as the umlaut here. And this pronunciation is, I'm not the best person here, but yes, Kreonig incision. Otherwise, a lot of people call it the Deeley's incision also. Deeley's incision, the lower segment vertical incision. All right, so you must know these incisions. And this, the scar on the uterus, these are the ones which can cause ectopic pregnancy. The uterine scars are the ones which will have the ectopic. Don't say the abdominal scar has ectopic. Uterine scars have the ectopic. Now, when I ask you scar endometriosis, that is the abdominal scar. So, scar endometriosis, yes, that will come in this abdominal scar. Okay, vertical or transverse, scar endometriosis. And scar ectopic, which I already showed you, scar ectopic is this one, right? Right, so that's a lot of revision we had. And okay, I've been following this. Lalit Dagar, that's oh God, I can't see. It's not just cosmetic, but there is Vipin Esha, you're mixing a few things, okay? The abdominal incision is cosmetic, you know. Abdominal incision is in fact only cosmetic. You know what happens? That whether you cut the abdomen vertically or you cut it transverse, both these incisions can be given. So don't get confused, Vipin, because I cut the abdomen vertical and I cut the uterus transverse, I can give trial of normal vaginal delivery in the next pregnancy. If I cut the abdomen transverse and I cut the uterus transverse, I can give trial of normal vaginal delivery in the next pregnancy. So, abdominal scar is actually only cosmetic. Yes, abdominal scar healing might be better in a vertical more than the transverse. All that we'll discuss some other time. But what you wrote, वो एकदम correct नहीं है. ठीक है? Please understand. Lower segment incision is what is required for a trial of labor next time. Abdominal incisions are cosmetic importance in cesarean section. Okay? Right. So let's move on and see something else. Name the instrument which the surgeon is applying on the angles of the uterine incision in this procedure. Look, again, I'm not telling you the procedure. You have to understand these things now. See this. Now, there's a Doyne's retractor here. But now we are, yes, this is the open uterus through which the baby has been taken out. Now, see this instrument which is applied here. See this instrument which is applied. Now, you should know, all you guys have done internship. You should know that we are applying this instrument on the angle. Can you see lovely depiction of the angle of the uterus where we are applying this? So, to hold the angles of the uterus, once again, can you see the baby is out? Before we start suturing, I'm making this video. This is my senior resident who was doing the surgery, and I told her to make sure that she shows me this instrument nicely. Yeah, see this one, yes. And she's applied that and she says, okay, fine. Yes. Now she's okay, stop. Okay, see this one. Yeah. So it's applied on the angle of the uterus. Now, when you're applying it on the angle of the uterus, it is to stop the bleeding and also to help us start the suturing. And sometimes these angles will extend and they'll also have the uterines bleeding. So to make sure the bleeding is less, we apply this instrument. So what is the name of this instrument? Yes, is it the Alice forceps, which is used? Yes, a lot of us in hurry, we actually use the Alice forceps, can be used here, but Alice forceps has teeth, so it can actually cause the teeth, at the tip, they can actually cause injuries. So Alice is used, but which is the ideal instrument, which will not hurt the uterus and which will give a good compression. It's a little broader. Yes, you're right. Those who are writing B, the green Armitage forceps. So those who said green Armitage forceps, that's the name of the doctor. All right. It's a British doctor, Green Armitage. That's the name of the doctor. Okay, it's not a Green Army ka instrument aisa nahi hai. It is a Green Armitage. That's the name of a gentleman, a gynecologist in the British days, and he was a very successful British gynecologist who was working in India. Then after after we got independence, he was the head of the Royal College for a long time. So he did a lot of good work when he was working in this part of the world. And that's Green Armitage. Now, this is not the bulldog clamp. Bulldog clamp is used for vascular surgeries and not the coccus forceps. Oh, I should have got a coccus forceps. Coccus forceps, I'll just tell you first, this is the Green Armitage. Green Armitage, you see, it's a flat instrument at the tip and it's got these serrations. So they don't hurt, they will compress nicely. So the tip has these serrations, that's the Green Armitage, the first one here. And the second one here is the bulldog clamp. These bulldog clamps, yes, the general surgeons and the vascular surgeons are well aware of this one. They generally use this. The best thing about these bulldog clamps is that they're very light. So when you're doing a vascular procedure, and we also, when we are doing these internal artery ligations and when you're doing the dissections for the Wertheims, so all these blood vessels, when you want to just clamp for some time before we want to reduce the blood loss, so these bulldog clamps are very light. So when we don't have much space, small instruments, very light, we can put them on the vessel and they will hang on the vessel but not tear the vessel. That's why they are very light and very handy for stopping the bleeding. Now the coccus forceps, I should have got you the picture here. The coccus forceps, the tip is something like this. Okay, if you see, the tip will have teeth like this and one like that. So these coccus forceps, if you see, like this. You take this coccus forceps inside the uterus, go to the cervix and reach the amniotic sac, hold the amniotic sac and pull. So you break the amniotic sac with the coccus forceps. So that coccus forceps, which is here. So answer for this is Green Armitage, and coccus forceps is used for the artificial rupture of membranes. When you want to do an ARM in obstetrics, of course, that is one of the uses. We use the same coccus forceps when I've done a hysterectomy and I have the vault to suture, the vaginal vault. When I'm doing an open hysterectomy, the vaginal vault is left to be sutured. So I use the coccus forceps there. There are many other instruments. You can use the Alice forceps also, a longish Alice forceps for holding the vault to do the suturing. So coccus can be used there also, but classically it is used for doing the artificial rupture of membranes. Right. In this transvaginal ultrasound of an early pregnancy, a flickering is seen in the gestational sac. What is the earliest duration of pregnancy when this can be seen on a transvaginal sonography? Okay, take your time and understand the question. We are doing an ultrasound and there is a small gestational sac. Can you see there's a small yolk sac here, and you'll see a flickering. Obviously, that flickering is the fetal heart rate. The earliest fetal heart rate will come as a small flickering. So very simple question, that when do you see the fetal flicker on transvaginal sonography? Just that, we give you a video based question and just hold the information a bit so that you get nervous. So see this video here, gestation sac, and now the yolk sac here. Next to that, can you see here? You will see a flicker here. See the flickering here. Can you see this flickering here, guys? Once again, yeah, it'll come. Yeah, see here. See the flickering here. So you can see this is the gestation sac, this is the yolk. This again is zoomed in picture, and this is the flickering here of the fetal heart, the earliest fetal heart. So yes, when can you see cardiac activity earliest? Okay, A, B, C. Most of you saying A, 4 weeks and 3 days. Some of you seeing 5 weeks and 3 days. See, gynecology will say 5 weeks and 4 days. Radiology will say 5 weeks and 2 days or 3 days. Thoda sa variation hota hai, but mostly 1 or 2 days ka variation is there. So generally we give you a roundabout value: 4 weeks 3, 5 weeks 3, 6 weeks 3, and 7 weeks 3. So that confusion come hai. All right. So C, 6 weeks and 3. So yes, a few people have got this wrong. Okay, chalo, I'll just show you. So the answer I'll mark you later, but let me show. On ultrasonography, a gestation sac on a transvaginal sonography can be seen as early as 4 weeks plus 3 days. A cardiac activity can be seen as early as 5 weeks plus 3 days. Now, whatever you see in a TVS, you see 1 week later in a transabdominal sonography. So 5 weeks plus 3 days, you see the gestation sac on a transabdominal sonography, and 6 weeks and 3 days, you see the cardiac activity. So what did we ask you? When do you see cardiac activity earliest? So earliest cardiac activity, transvaginal sonography, 5 weeks and 3 days. So that's the answer which I was looking for, and quite a few of you got that correct. 5 weeks and 3 days. B is the answer for this question. So 5 weeks and 3 days, you see the cardiac activity earliest. So this question has come in exams. What is the earliest? What is the earliest documentation of a fetal heart rate? Now don't say fetal Doppler. That's a wrong answer, guys. What is the earliest documentation of the fetal heart rate by any method? So if you say fetal Doppler, that is 12 weeks. Stethoscope, 24 weeks. But the earliest you can document a fetal heart rate is by a transvaginal sonography, not even transabdominal. Transvaginal is 1 week earlier. So 4.5 weeks, you see the gestation sac, and 5.5 weeks, you see the cardiac activity. Earliest documentation of fetal cardiac activity is 5 weeks and 3 days. Right. I've got another question. Okay, fine. Before that, what are you guys saying? Okay, some of you said B, quite a few said C. Okay, guys, chalo, let's move on and see something else. Next question. In this transvaginal scan of an early pregnancy, a 10 centimeter lesion is seen next to the uterus. What is the best time to remove it? Next to the uterus in an early pregnancy. Next to the uterus in early pregnancy. So now that's what you have to see. Okay? See this. See, there's a cystic lesion. You see a big cystic. This is actually 9 centimeter, 9.5 centimeters. The calipers are not shown because it's a zoomed in view. And there's a pregnancy here. Can you see the cardiac activity will come here now? That flicker you're seeing. The flicker here and the large cyst here. Yeah, can you see the flicker here? So this is a TVS. Can you see this? This is the transvaginal sonography, and you're seeing this is the uterus, and you're seeing a fetus with the cardiac activity, and you're seeing a lesion. Come once more. The clear cystic lesion, 9 centimeters, 9.5, almost 10 leke chalo, almost 10 centimeters, and there's a fetus here. So pregnancy with an ovarian cyst. So I have told you the answer. I mean, already you know what is the question. They could have just written this question, you could have gone ahead and answered, but you have to now see and understand there's a pregnancy and there's a cyst next to the uterus. Next to the uterus, big cystic lesion will be an ovarian cyst most of the time. I mean, like, we are not going to ask you the rare retroperitoneal cystic lesions. Please, we'll ask you common things. Okay, so do not get into, you know, ye bhi to ho sakta hai, wo bhi to ho sakta hai. If you talk like that, then there is no end to discussion. We are going to ask you obviously core basics. Any exam, whether it's your NEET exam or UPSC exam, INICET exam, or your FMG exam, we always ask you core basics because we want you to pass the basic understanding MBBS and then become specialist. So core basics, yes. In NEET exam, we ask you a lot of core basics. Yes. So that's why it becomes a little more tougher than the other exams. Chali. Can't reach diagnosis. There's a pregnancy with a lesion next to the uterus. I've already given you the answer. It's an ovarian cyst. Once again, see this. There's a cystic lesion next to the uterus. It's 9.5 centimeters. Cystic lesion in the ovary. That means ovarian cyst. Next to the uterus will be an ovarian cyst only. And there's a pregnancy inside. There's a pregnancy inside the uterus, which is a live pregnancy. So this video has been shown to tell you that there's an ovarian cyst in a pregnancy. Ab batao, 10 centimeter lesion next to the uterus, what is the best time to remove it? So when do you remove ovarian tumors in pregnancy? Now that question, you know the answer. But if I show you like this, you're not getting the diagnosis. That's where the video-based questions become a little tough. So yes, second trimester is relatively safe. See, fat se aa gaya na answer, Jayalakshmi? Good. So once you know how to, that's why I say keep visualizing. It's all right. You know, second trimester ovarian cyst can be removed the best. So yes, answer is correct. That we remove it in the second trimester. No, we don't say D along with the cesarean section. No, 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 not the best time. No, not the best time. If you diagnose the ovarian cyst in early pregnancy, you must remove it in the. देखो इतना समझाएगा नहीं कोई आपको exam में. If you got a video-based question, nobody is going to try and tell you in so much of details. Yes, you have to understand. There's a pregnancy, live pregnancy with the beating heart. Next to the uterus, there's a cyst. What can be the cyst in a pregnancy next to the uterus? Next to the uterus, you should know ovarian tube ही होता है. And there's a nice circular cyst, 10 centimeter. Anything more than 8 centimeter is called a large cyst in pregnancy. More than 8 centimeter is a large cyst. So you have to surgically manage because the ovary can undergo torsion. So understand that. Suppose this is the pregnancy and normal ovary with the ovarian pedicle is like this. Now this ovarian pedicle with the 10 centimeter cyst. Now this cyst can undergo a torsion and it can rupture, it can cause hemorrhage, it can cause not only abortion, it can even cause death of the mother. So rupture of the cyst can happen, torsion can cause gangrene, so the severe pain can happen, pain can cause shock. So we don't want the cyst to persist. So second trimester, yes, is the correct answer. The safe trimester to do any surgical procedure. So second trimester is the safe procedure, we'll do it. And yes, a lot of you answered D for Delhi also. Why? If the tumor was diagnosed in the third trimester, suppose a woman was never doing a antenatal checkup and she comes to me only in the third trimester, she comes to me, let's say at 32 weeks. At 32 weeks, there's an ovarian cyst, or 28 weeks, there's an ovarian cyst. I'm not going to remove it then because now the risk of preterm labor increases a lot when I do a surgery. So I will wait for the normal delivery to happen, and after the delivery, in the next 1 week or 2 weeks, when the uterus actually reduces in size, I will not wait till the end of the puerperium, because the uterus, when it reducing in size, this uterus will pull on the cyst. So on the spine, when the ovarian cyst is getting pulled down slowly, and on the bowel, when it is getting pulled, it can undergo a torsion. So we don't wait too long. Delivery has happened, in the immediate puerperium, first week or the second week, we do the cesarean, we do the removal of the ovarian cyst. Now, suppose you end up doing a cesarean, that is a choice D. Suppose the woman has a breech presentation, which is a complicated breech with IUGR. Suppose there's a transverse slide, or there's a baby which is more than 4 kgs. I'm saying we can't give trial. More than 4 kgs macrosomia in our country, right? That's the definition. So if it is, we are doing a cesarean for whatever indication, then you do the cesarean, take the baby out, and along with that, you can do a removal of the cyst also. Yes. So I don't know whether I have it here somewhere. Let's see. Maybe I can show that to you also. Yeah, that's me doing a removal of an ovarian cyst while doing a cesarean section. So this is the uterus here. You can see this is the uterus, and I've done a cesarean section already, and there's a huge ovarian cyst. This video is also there on the YouTube. It's a patient who's had a transverse lie and I had to do cesarean. This woman had lost 3 or 4 abortions, then she was infertile, and then this pregnancy, she had a huge ovarian cyst. I operated it during the pregnancy, still it recurred, and then with the cesarean, I had to do a, so that's a, oophorectomy I'm doing. I'm taking out the ovary altogether. It's a huge thing. Can you see that jelly kind of thing which came out? So it's a mucinous cyst in pregnancy. Right. So I think get back to work, what we were doing here. Right. So you can remove it. You can remove it along with the cesarean also. Okay. Fetus and the uterus small. Yeah, it's not safe. First trimester is organogenesis, and if you give anesthesia, okay, fine, that's a good answer. Ishita Biswas, it's a good answer, because first trimester, if I have to do surgery, anesthesia has to be given. Anesthesia can have its effects. Some anesthetic drugs can cause abortions also. Not that we do a lot of surgeries in the first trimester, aisa nahi hai, but yes, panga kyun lena? Why to do it? Yes, correct. I will agree with your answer. And risk of abortions are more in the first trimester. It's a delicate time, and we would not want to do a surgery. Okay, but dekho, this all information which you've given me, it's good when there is no emergency. I do the ultrasound of an early pregnancy, it's a 9 weeks pregnancy, and along with that there's an ovarian cyst, and there is no pain. When do I remove it? I remove it in the second trimester. Suppose a woman comes to me with acute abdomen, she comes with a pain abdomen, and she's 9 weeks pregnant with a huge ovarian cyst. I'll take it out there and then. I'll have to take a risk, because if I leave the tumor which is getting twisted, torted, and causing ischemia, or maybe bleeding, rupture, I have to do an emergency surgery. Then we'll take a risk and go ahead. So we are not talking about emergencies. Planned cystectomy, best in the second trimester. For that matter, a woman has a mitral stenosis, then she's got a critical mitral stenosis. You know, at around 30-32 weeks, the cardiac load will increase, and she can go into failure around 30-32 weeks. So when do you do a balloon mitral valvotomy in a pregnant woman who has severe mitral stenosis? Second trimester again. So any planned procedure is done in the second trimester. That is what is the idea. So yes, your good answers. Okay, thanks Dr. Inesh and Dr. Mohammed Mukhtar Ahmed. And any specific contraindication for first? Yes, I just not told you that. Okay, chaliye, let's move on and see something else. Another one. The following method of fetal heart auscultation is using which instrument? Yes. Following method of fetal heart auscultation is using which instrument? Yes. Okay, my third year PG. Now she's an infertility specialist. She's got her own hospital. Very hardworking doctor. So this instrument here is used to auscultate the fetal heart. This is the right occipital posterior. If it is a left occipital posterior, we would have been doing it here. This is the right occipital transverse. I think I said posterior. I'm sorry. Right occipital transverse. Left occipital transverse, you do the auscultation here, and the right occipital transverse, you will do it here. So when you got this instrument, yes. What is the instrument? Yes. What are you guys answering? Is the Pinard's fetoscope. Yes, it's a conical instrument. I think I did not get the picture of that here. I forgot, I think, but I'll show you. Yes, it's a conical instrument like this. It's a favorite amongst the senior doctors. You know, I would always love to use this more than the stethoscope. But yes, a lot of people are happy using the stethoscope, and this Pinard fetoscope is this is a metallic instrument. Steel, aluminum is the general method, but some of you, those who have done your MBBS from the Western countries and also from the colder countries, you would see this as a wooden instrument also, this Pinard fetoscope, because in cold countries this aluminum and steel will give a cold shock. So yes, that's a Pinard fetoscope. So that is Pinard's fetoscope. Now you can use the Doppler. See, this is the Doppler. This is the Doppler. By this you can see the fetal heart rate as early as 12 weeks. So Doppler is 12 weeks. Now stethoscope and the Pinard fetoscope, both. This is around 24 weeks and later. 24 weeks and later, right? So that is the stethoscope. So please, the earliest documentation of the fetal heart rate, is by the transvaginal sonography. 12 weeks, the fetal Doppler can pick up the fetal heart rate, and stethoscope is 12 weeks. Pinard fetoscope is 12 weeks and beyond. When can the mother feel fetal movements? Mother can feel fetal movements around 16 to 18 weeks if she's a multigravida, because she's used to the pregnancy and she can make out that I'm getting fetal movements earlier. A primary gravida, 20 weeks and beyond, she can get the fetal movements beyond 20 weeks. Say, okay, all of this is there in the chapter of physiological change of pregnancy. Of course, those who have the PW Merit app, you would always see the lectures, and I'm sure you'll correlate well. Okay, and please just taking the opportunity for you to enroll with the PW Merit FMG1 plan, which is the best way for you guys to get into the preparation for your January MCI 27 exam. And we will have all of this, you know, we have a roadmap ready for you. Rapid revision July to August, along with the main videos you must do. And then August, November, you do the TNDs with us, which is under the guidance of your teachers, 19 teachers. Then you do the grand test in November and December with the video-based questions and the image-based questions. And December to January, you do the marathons with us. We do the marathons live, and then you're good to pass your FMG exam. Right. So, any doubts, guys? I'm here. 6 weeks, yeah. So, can you please explain modified Shirodkar? Modified Shirodkar is just a stitch, you know. The Shirodkar is now called the modified Shirodkar. Pehli baat. So, if both the choices came, it was an unfair question. The Shirodkar which we do, like the Pomeroy's which we do, is nowadays called the modified Pomeroy's. Nobody does the basic Pomeroy's for the tubectomy. So, the Shirodkar which is done is called the modified Shirodkar. And the modified Shirodkar means that when you're putting the stitch, before that you see the cervix is very small. So, this is the bladder and this is the cervix. Now, you want to put the stitch, yes, you want to put the stitch, where do I go for the background? Yeah, here. So, when you want to put the stitch on the cervix, you want some stump of the cervix where you put the stitch, cerclage. Now, the bladder is here. Normally, a short cervix, you'll put a stitch here somewhere. Now, the bladder is here because the cervix is very short and you cannot put a stitch. See, if you want to put a stitch, the bladder is coming in the way. So, this is the anatomy. So, what happens if I want to put a stitch? I will dissect the bladder away from the cervix and I'll put the stitch here and then put the bladder back. Now, the stitches are enclosed all over, on the top by the vagina, on the back by the vagina, so that the stitches are not hanging the vagina, so that there are no ascending infections. So, covering the sutures, I'll try to show you here. Wait a minute. I'll buy some space here. So, if you see this, now if the cervix is like this, let's say this is 2.5 centimeter and smaller, then I can put a stitch on this much easier. But if the cervix is short, if the cervix is very short, let's say like this, and she's a pregnant lady, and see here now, and the bladder is on the top like this. This is what I was trying to show you with my hand. Now, how do I put a stitch here? I cannot put a stitch here because the vagina and the bladder is covering the top and the posterior vagina is covering the back of the cervix. So, how do I put a stitch on this? So, to put a stitch on this, I have to dissect away this anterior vagina, dissect away the posterior vagina, and then apply the stitch here. So, apply the stitch here, and then I will close this. I'll use a different color to show that now I'll close this. So, now you see, when I look at this stitch from the vagina, when I open the vagina and see, I cannot see the sutures, the red knots, I cannot see. Why? Because they are beyond the vagina, they are in the supravaginal part of the cervix. So, I cannot see the stitch. So, earlier people used to hang the stitch inside the vagina. Now, we keep the stitch inside so that there are no ascending infections. So, that is a modification of the Shirodkar. वही पूछते यार. So, Shirodkar is done for very short sutures. Shirodkar is done for a very short cervix or a previously mutilated or a previously failed cerclage. Mutilated cervix या failed cerclage होता है तो उसमें हम लोग Shirodkar करते हैं, right? Yes. Right. Dr. Inesh has been full of compliments. Thank you so much. What is the management of covular uterus? Covular uterus is abruption. Covular uterus is an abruption, my friends. Next time I'll show you a video on abruption. Covular uterus abruption. Abruption का management क्या है? deliver as early as possible. So yes, you induce labor by ARM and do a normal delivery, but if there is fetal distress and it is taking time, you can do a cesarean also. So don't say that abruption is equal to cesarean section. There are hundreds of babies we have had abruption, we've delivered them normally. They're all big grown-up adults and doing a very good thing in their life. They're all, we have followed up so many of them, because some of them are your children of our doctor friends. So abruption will deliver normally, okay? Don't worry about that. But you must do the delivery. In placenta previa, you can do conservation. Sometimes if it is like a preterm patient and she's before 34 weeks, placenta previa you can do conservation. Covular uterus, abruption placenta, do a delivery, do ARM, do a normal delivery. Yeah. Right. So UPSC exam, I'm doing the mock. Yes, we'll send you the mock answers very fast. But yes, remember, Jayalakshmi, don't lose heart. The UPSC exam is a standard exam. It's tougher than NEET. I'm telling you that. This UPSC exam was meant to make sure that the people getting into government services are smart people. Yes, I'm very open about this. We have to be, when we are so many of us, so many Indians, how does the government decide whom to take into the services? They'll have to get the best brains. So I know we are just too many of us. So the exam is getting a little tougher. UPSC exam, at least you have the questions. I'm so happy that I want each and every exam in the country to have the questions at least given. Okay, if you give the answers is even better. But at least the question should be given so that we can, all of us, know that what are the questions coming. Most of you, when you recall the questions, then the choices are not properly given to us. So we are always guessing what came. So at least the UP exam is a good exam for you to practice for the NEET PG. And just in case you pass UPSC, it's a good place to get into work. I mean, start working for the government, and while working for the government, you can do your post-graduation. Government gives you leave to do the post-graduation while you're serving for the government. So it's not a bad thing to do. Okay, so go ahead and don't feel you don't feel dejected with the UPSC exam. It's a good standard exam. It gives you a good insight about your preparation. You know that there were so many topics you did not read about. So it's a good thing. And yes, Ugrasen, I'll be happiest to see you after the exam. Right. Thank you, guys. Thank you so much, and lovely taking your session. And we shall keep meeting on the PW forum for a lot more sessions. God bless you guys. Do a very good exam.